What physical therapists need to know about ACL injuries. What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists. Like always, we go through the literature, pick out the good stuff, throw out the bad stuff, add our practical experience, and teach you a thing or two. How's it going today, Kevin?
It's going well. I am very excited about this topic here, Dan. I think there's a lot of things physical therapists need to know about ACL injuries.
My God, it's going to be action packed. All right, what are our learning points for today? We're going to go over prevalence, population, anatomy, biomechanics, mechanisms of injury, and predisposing risk factors for ACL injuries. You ready to do this, Kevin?
Let's go.
Let's go. Let's start off with prevalence. So, ACL injuries are a common injury in physically active individuals. There are approximately 250,000 ACL injuries that occur per year in the United States of America. And around 50% of those injuries undergo ACL reconstruction, which I thought was pretty interesting. So essentially, about half of folks that get ACL tear end up getting surgery, half don't. We'll talk about surgical versus conservative on a later show. There's an incidence of approximately 85 injuries per 100,000 in patient aged between 16 and 39 years. Probably should edit that a bit better because that sentence sounded terrible, but I think you guys get the point. And every year, around 3% of recreational athletes injure their ACL, and then up to 15% of elite athletes will tear their ACL. We'll talk about this a little bit later, but it does seem that as you progress up the ladder of more challenging sporting levels, there's a higher incidence of ACL injuries. Anything to add there before we move on, Kevin?
Just that's like a staggeringly high number, like 250,000 athletes per year in the US. And it doesn't seem to be going down over time. So that is definitely something to keep an eye out on and figure out why and what we can do to minimize tears.
I think it's great. Great for business, man.
Keeps us
I'm just
busy.
kidding.
That's definitely true.
Yeah, we would not be, living as lavishly as we do if it weren't for these folks. Hey there. Sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video. Just kidding. All right, so what population do you see this in? So it's greatest in athletes between the ages of 19 and 40 years old. I think part of this is just because we kind of stop playing sports as we get over the age of 40, right? And then non-contact is the primary mechanism of injury. This does change a little bit based on the sport you're involved in. I mean, if you think about football, there's going to be more contact injuries, right? Than you're going to see in something like soccer, just based on the nature of the sport, right? And we typically see this in pivoting sports. So think about soccer, basketball, football, volleyball, handball, gymnastics, and skiing. I always think it's funny when I look at a study and they say like the most common population for the injury is in netball. I'm like, I don't even know what netball is. You know what I mean? It's like, why didn't you include soccer? Everyone knows what that is.
Yeah.
And then, and this is a big one. So these injuries tend to be much more common in females. And it really depends on the study you look at, but somewhere between 2 and 8 or so females are around 2 to 8 times as likely to sustain an ACL injury compared to their male counterparts. Any of that sound new, exciting, weird, interesting to you, Kevin?
I think that's pretty in line with what we see, right? We tend to see ACL injuries occurring most frequently in younger athletes, high school, college age. Definitely seems more prevalent in females, just anecdotally. Like a lot of the athletes we have coming in are lacrosse players or soccer players or, field and court sport type athletes. That definitely seems pretty common. But definitely, like you said, we do see it in people older than 40 as well. But I think you're probably spot on with why. It's just that older people aren't doing field and court sports at the same frequency as younger people. So you will see it more commonly in that younger population. But I think across the age spectrum, you can expect to see some people present with this type of injury.
Yeah, we see a lot of skiers too. And some of these studies did mention downhill skiing, but recreational skiers all the time. I'd say that's one of the biggest populations that we see. When I was in Denver, Colorado, we saw a crazy amount, probably more ski injuries than sport injuries, right? So yeah, you definitely see that with skiers as well. All right, a little bit about ACL anatomy. I apologize to the folks that are listening to this. If you're listening to this at some point, if you want to see this a little bit better, you can go to YouTube and check out the video there. So ligaments connect bone to bone, right? So the ACL is no different. It attaches from the femur to the tibia, and it blends with the anterior horn of the medial meniscus, which is interesting, right? Sometimes the two are injured together. So it does attach with the meniscus a little bit here, right? And you can see that they kind of cross in the center of the joint, kind of goes from the front of the joint to the back of the joint. And the same thing with the PCL. So you think about cruciate or cross ligaments, they kind of cross together on the inside of the joint there. And there are also two parts of the ACL. You have the anteromedial bundle, or the AMB, and this is typically a little bit smaller, and it's lax in knee extension, but then it becomes taut or it tightens in knee flexion. And it's a primary stabilizer and higher degrees of knee flexion. In general, if you flex the knee to around 90 or so, it does slack the ACL more in general, but these bundles actually behave a little bit differently. You also have the posterolateral bundle, or the PLB. And this is larger, and it's tightened or taut in knee extension. So kind of the opposite of the anteromedial bundle. And it's a primary stabilizer in knee flexion, less than 30 degrees. So as I get closer to full knee extension, helps to reduce rotation and shear within the joint, and it's more lax in knee flexion. Any thoughts on that, Kevin?
No, yeah, just interesting anatomy, and something to keep in mind is that there are different bundles that have slightly different functions, and maybe plays a role in, like you said, what forces are being resisted. So just something interesting to keep in mind when we get into our special tests. If we're seeing certain things, it could give us maybe some insight into where the tear may be.
Yeah, and I think that these are getting a little less popular. I'm not sure. But I remember when the double bundle technique from a surgical repair standpoint or reconstruction standpoint was very popular. So they can try to reconstruct both of these bundles in surgery too. So more relevant in a future podcast episode. All right, let's talk a little bit about biomechanics. What is the function of the ACL? So it resists anterior tibial translation, is the primary restraint to anterior tibial translation. So you think about your anterior drawer test, patients laying on their back, knees bent to 90. We grab the backside of their knee on the tibia. We try to pull it forward, right? And if the ACL is intact, it shouldn't move very much. If it's not intact, it tends to move a little bit more, right? The ACL is also going to prevent tibial internal rotation, particularly in knee extension. And spoiler alert, this is the common mechanism of injury you tend to see in these folks. So the knee is close to full knee extension, and then we have a valgus load. The tibia may or may not go into internal rotation, sometimes an external rotation, but this can tear the ACL. And ACL deficient knees present with more tibial anterior translation, as well as rotary instability, which makes total sense. The ligament is either stretched or gone, then you're going to have more motion at the knee. Another thing that's going to be very relevant is that the ACL contains mechanoreceptors that influence neuromuscular control of the knee. So after you have an ACL injury, we want to work on things that restore proprioception, balance, neuromuscular control, so on and so forth. What do you think about that, Kevin?
I think you're spot on there, dude. Good job. Got nothing to add there.
All right, let's move it on then. Let's talk about mechanisms of injury. And I thought this study was great. I tried to use relevant recent articles for this presentation just because there's so much ACL research. It's really hard to stay on top of. And one of the things that I found, especially in the risk factor section, is that new research will invalidate old research, and then newer research will revalidate the old research, and back and forth, so on and so forth. So it's a little bit confusing. And I wanted to use the most up-to-date literature that I could find. This study was in arthroscopy in 2024, and it's called Most Anterior Cruciate Ligament Injuries in Professional Athletes Occur Without Contact the Injured Knee, a systematic review of video analysis studies. So essentially, they're looking at athletes that tore their ACL, and they're remarking about how they did it, right? They were looking at 13 studies, 542 athletes, and this was 91% pro athletes and 71% male, which we know is maybe not the most accurate reflection of the average person that tears their ACL, because we tend to work with a lot of folks that are, say, high school athletes, right, or middle school athletes. We also see a lot of ACL injuries in females. So take this with a grain of salt, but it was very up to date, and I thought it was pretty good, and it was very similar to other studies I saw. Essentially, 33% of the athletes in this study, soccer players. Football was the second most common with 26%. And they had a whole bunch of other types of sports included in the study as well. So they saw 42% of those injuries were non-contact injuries. And here's what I will say. That's a little low compared to the other studies that I saw, because you'll see other studies that show around 70% of all ACL injuries are non-contact in nature. This one's quite a bit lower. And I'm curious if it's just because there were so many like football injuries, or there may be more contact sports included, or maybe because there's more males. I'm not really sure. But that was one thing I saw that was a little bit different with this study compared to others. In terms of contact injuries, so they remarked on direct versus indirect contact injuries. So essentially, a direct contact injury would be a football player plants their foot, and then another player drives their shoulder into their knee, delivering a valgus force and tears their ACL, right? An indirect contact would be a person collides with another person, but doesn't directly hit their knee, hits somewhere else, right? That would be an indirect contact injury. And of those total injuries, indirect contact injuries made up 32% of all injuries. And then for the direct contact injuries, they made up 22% of all injuries, right? So in this study, it actually showed more contact injuries than a lot of the other studies, which I thought was interesting. What I will say is that most of the research on ACL tears are in non-contact injuries. I think the major reason why is that we feel like we can potentially change these non-contact injuries more so than the contact injuries. They're kind of happenstance that just kind of happen with the sport. Although I bet you we could probably try to prevent some of these contact injuries as well, you know. In terms of how these injuries occurred, about 91% of these injuries occurred with the foot planted on the ground. So generally speaking, the large majority of patients are tearing their ACL once their foot hits the ground. It's not happening on the opposite side leg that's in the air, or when they're in the air in general. The other piece is that 84% of these folks were at full or near full knee extension. So that's another big one. Once that knee flexes, it protects the ACL a little bit. When you're at or full, at your close to full knee extension, less likely to be safe. And this is one of the reasons why quad strength is so important, because if you don't have the strength to go into knee flexion when you land, cut, change direction, you might be more at risk for having an injury. But it's a double-edged sword, and we'll talk about that a little bit later too. Axial loading occurred in 81% of folks. So think about, let's say you're decelerating from a jump, you're loading up that joint. That's an axial load. The 50.4% of athletes had an ACL injury. This occurred during a deceleration or a shift in momentum, which makes sense. 36% of these injuries occurred while an athlete was pivoting. And then 76% of these athletes had some form of knee valgus with associated internal or external rotation. And that was 50-50 split. So about half of those folks happened with tibial internal rotation, half with tibial external rotation. So I thought that was interesting too, because I kind of thought that tibial internal rotation was the big one, but it looks like it's kind of split. And it seems like that knee valgus can just tear regardless. Doesn't matter where your spinning of your tibia is, you can tear that thing regardless. So any thoughts on that, Kevin, before we move on?
Yeah, I think one thing that just popped in mind, just curiously, if we do see higher rates of contact ACL injuries in men, and maybe if the study had more women for whatever reason, non-contact may be more common. That's just speculation, totally guessing, but seems potentially reasonable. But I do think like those are the mechanisms that we tend to see, is that non-contact, I think, is a little more common that I see. Like you had said, we see a lot of skiing injuries, and that tends to be non-contact, and they kind of get stuck in their ski, and they have either their planted foot in their ski with an internal or external rotation moment with that valgus stress. And I think using these types of mechanisms to, think about not non-op, but preventative rehab programs for ACL tears is something that I think a lot of researchers are always trying to figure out. So I think the more we understand about the mechanism, the more we try to apply those concepts in the gym preventatively. And hopefully that will continue to pan out over time. And as we get better at exercise dosage and prescription, maybe we can use that information to try to prevent, some of these tears from happening. So, we'll see what the future holds there.
Totally. Yeah, we'll definitely talk about that. There's a ton of injury prevention research too, very promising injury prevention research too, which I think is great. We'll talk about that a little bit in future episodes. Okay. What are some other common mechanisms of injury? So basically, valgus was only like 76% of injuries. How are other people getting hurt? So there are a couple other mechanisms that I think are important to think about. So knee hyperextension is one of those. In cadaver studies, they'll actually just bend the knee backwards until it breaks. And essentially what they find is that the ACL and the PCL simultaneously tear together. And I've certainly seen some patients that had their primary mechanism of injury was hyperextension. Knee bends backwards. Think about a flamingo. Their knees bend backwards. They do a flamingo maneuver. They go in for some imaging, and yep, looks like that ACL is torn. So that's a common mechanism. I've seen some patients have that. Whenever I see that, sometimes patients will say, well, I didn't have knee in, so I don't think I tore my ACL. And my thought is like, yeah, we'll see, hopefully it's negative with that MRI, but that can certainly happen. These are anecdotes. I tend to work in weirder sports. So I see a lot of Olympic weightlifters, and I've seen a lot of Olympic weightlifters tear their ACL now, which is really interesting, right? I can think of 3 athletes off the top of my head that I've seen that have torn their ACL with Olympic weightlifting, right? The one that's weird to me is push jerks and split jerks. So Sarah Sigmund's daughter is a popular CrossFit athlete who this happened to her recently, was performing a split jerk, right? If you think about a split jerk, you're driving a weight overhead. You would think that you're not going to injure your ACL when you do that. But essentially in a split jerk, that lead leg, you're kicking forward. And a few things can happen. My thought is that if you're directing the bar anteriorly, when you catch, that means that you're going to put more weight on that lead leg. And the quad is going to be very, very active when you land. The other thing about the split jerk is you're actively kicking that leg forward. So if you end up kicking the ground, you've got a very forceful quad contraction in the absence of a hamstring contraction. It's just like you're kicking the ground super hard, and then you're catching a heavy load overhead. So your quad has to be firing aggressively. And maybe that just ends up tearing the ACL. It shears that joint. I've seen the same thing happen in a push jerk. Athlete kind of pushed it forward a little bit more so than they wanted to. They caught the weight a little toesy, kind of weight on the front of the foot, probably fired that quad a lot, and then the ACL tore, right? You also see those freak videos where people are doing sissy squats and the quad is super active, hamstring is not, and then you see the knee just shear, bloop, and you probably just tear the ACL. That's a terrible injury. I had an athlete recently that caught a clean or didn't catch a clean, and essentially the bar dropped straight down. One knee went way into valgus. The bar dropped directly on his quads, and he actually had a bunch of injuries, but one of which was an ACL tear. With that, I've seen an athlete starfish with a power clean before, which means that you catch the clean, and as opposed to going into a deep squat when you catch the clean, you spread your legs out super wide, and then you have a valgus force the knee, and she tore ACL there. So you see a bunch of funky things in the fitness world, but I have seen a few of these just kind of interesting anecdotes. But yeah, the large majority are going to be in field sports, but you do see in the gym sometimes, just less commonly. Have you seen any really funky ACL injuries, Kevin?
No, I think the ones I have are a little more common with the field or court sport athlete or skiers, but I think that mechanism with the forceful quad contraction makes sense. I think in those examples, like a split squat or push jerk, if you're really pushing your foot forward in the catch, you're getting a lot of anterior tibial translation, and if it just happens, with the right timing and the right load, that tibia is going to keep going, and the biomechanics are such that you could tear the ACL. But I think it's interesting to think about how that would fit into return to sport, because I think once they're further down the road from their rehab, that's going to be something cool to get back to, where we're really putting on the brakes with that forward leg and, testing that ACL. So, yeah, I think that's definitely your population. So you see some crazy things there in terms of kind of scary things with all the load involved. But
Yeah.
yeah,
Yeah, they're like catastrophes when they happen, but they don't happen that often, you know what I mean? It's
yeah.
so freaky. I
Well,
don't
that
know.
one you were describing, the starfish, I thought you were going to say she had two bilateral ACL tears because that would be a nightmare. But I'm sure that
Yeah,
that's happened, right?
just
Got
one.
to.
The other athlete I was talking about, he had like 3 surgeries. He had 2 surgeries back to back because he tore quad tendon and quad muscle, right? And he tore his ACL too, but they actually staged that. They did the ACL later. So
Wow,
that was a tough one. He's doing great now, though. It's really
that's
cool. It took him
awesome.
a long time to get back, but
Mm.
way to go. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain Free mini course. I've made an absolutely free mini course and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. All right, so let's look at some predisposing risk factors. These were anatomic risk factors, and I found a really nice up-to-date study to try to investigate which risk factors are going to be relevant for ACL injuries. This study was from the American Journal of Sports Medicine 2024. This is really nice because there's a lot of prior research on this. And essentially, what the study had stated was that there are a lot of different risk factors that had shown to be predictors of future ACL injuries, except these weren't great studies. They weren't really high powered. So what they wanted to do was to look at some of these risk factors again and see if they actually ended up being true risk factors. And there are a lot of prior risk factors, intrinsic risk factors, that are shown to correlate with ACL injuries. So some of these in females are high body mass, knee hyperextension, and anterior-posterior AP laxity of the knee, decreased ACL size, narrow intercondylar notch, increased posterior tibial slope, poor tibiofemoral congruity, and increased hip anteversion. For males, you'll find generalized joint hypermobility, and knee hyperextension increases ACL injury risk. So all of these risk factors have been shown to increase your risk of ACL tears in the future. Now, one of the other things that this study looked at was whether or not having certain variables present after your primary injury and primary surgery will increase your risk of having a secondary injury. And they found a few different things that actually did correlate with a new ACL injury after the primary one. And those were having a medial collateral ligament injury of grade equal to or greater than 2, lateral meniscus posterior root tears, medial meniscus ramp lesions, and an anterolateral structure injuries. These are all associated with residual rotary laxity and have been shown to be risk factors for ACL failure, as well as younger age, increased posterior tibial slope, and knee hyperextension. So all of these things were in the past shown to correlate with another injury after a prior ACL injury. So like I was saying, in this study, they were trying to have more people in the study to increase the power of the study. And they included 880 non-contact ACL injuries. It was higher powered than some of the prior studies. And they looked at all of the risk factors that we just mentioned previously to see if it held up in a higher powered study. For female athletes, static knee valgus was significantly higher in the new injury group, and the tendency was clear in the previous ACL injury players. So essentially, if you have regular valgus, not dynamic valgus, okay, so if you just stand up nice and tall and the knee comes in when you're standing straight, that was a risk factor for getting a primary ACL injury, an even stronger risk factor for a secondary injury, right? And then players with a secondary injury also had a higher degree of genial recurvatum or knee hyperextension statically as compared with previously injured players who did not have a secondary injury. So it wasn't a risk factor for primary injuries, but it was a risk factor for the secondary injuries, right? And I think the takeaway with this study is that all of those intrinsic factors we talked about previously had correlated with an increased risk of injury. When we looked at it in this study that was higher powered, it seemed that they weren't risk factors. Okay, so you have to take that with a grain of salt when you're looking at some of these older studies, because the newer studies weren't showing the same thing. Any thoughts on that before we move on, Kevin?
Yeah, that's interesting. So just to clarify, so the first slide that was showing all those things that predispose people to ACL injury were in previous studies versus the newer study that was higher powered was showing that what seemed to correlate with increased injury risk was static knee valgus and kind of hyper knee extension or genu recurvatum. Is that correct?
Yeah, only for the secondary ones though.
So that's a secondary injury after they
Yeah,
already
so
went through reconstruction.
overall, what they said is that there's little to no correlation of anything with these injuries. And I think that's relevant just because a lot of the prior studies did show a connection. They were just really underpowered. This one
Mm.
had a higher power to it, just more participants, and they showed there wasn't a connection between all of these things. So frustrating, but this was a better study, most likely.
But I think good too, because I do hear sometimes people, blame their anatomy or, think that they were, destined with this bound to happen because of their anatomy. And, maybe it's a good thing if we keep finding out that there's maybe it's more, biomechanical and sport force related than your specific genetics. I'm sure there's got to be some combination, but, I think that's so important is that we look for studies for answers, but some studies just aren't the best studies. They're not high powered or they don't have the best methods or whatever. So it's good when better studies come out that we can bring awareness to that and just something to keep an eye on as the research progresses.
Yeah. I also feel like we probably need to get an expert on here to kind of someone who's like sifting through this research all the time,
Right.
right? To
Yeah.
give us some more answers. Because one of the things I found is that as I read through everything, I was like, there's a lot that I still don't know, despite like going down stupid rabbit holes and reading all these studies. So yeah, we'll do our best to do that in future episodes, do some interviews, right?
Yeah.
Okay. New study, intrinsic risk factors for non-contact ACL injury in young female soccer players. This was 145 female Japanese soccer players, and they're looking for potential risk factors for non-contact injuries, similar to the last study. They're looking specifically at intrinsic risk factors, and they took 25 different variables. So this was kind of cool. They're looking at a lot of different things too, and this consisted of anthropometric data, joint range of motion, muscle flexibility, muscle strength, and balance measurements. They basically monitored these players throughout a single season for non-contact ACL injuries, and they found 13 total injuries. So not a ton of injuries, right? But this was a recent article, so I wanted to include it. I would have liked to see some more recent systematic reviews. I'm sure they will pop up more so, right? And what they found as risk factors associated with ACL injury were lower hamstring to quadriceps ratio, or the strength of the hamstring versus the quadricep. Generally speaking, I went back and kind of looked at what's acceptable in terms of being protective, and it's around a 0.6, right? So if you had a 1-to-1 ratio, that would be, let's say, 100 pounds of force in knee extension, 100 pounds of force with knee flexion, which would be very odd. Normal is somewhere between 50 to 80% of hamstring to quad ratio. So if you're below about 0.6 or so, your risk of injury goes up, which I thought was interesting because I learned a little bit about this in college, and then I didn't see a ton of it in the medical literature. And here's a more recent article showing that it's still relevant, right? And there's two thoughts. So essentially, if your hamstring is not strong enough, then when you do like a landing or cutting maneuver, you're going to rely more on the quad. The quad is going to pull the tibia forward, and the ACL prevents that. So if you're overusing your quad and not using the hamstring, what may happen is that the tibia is being pulled forward, the ACL is getting stretched. The hamstring normally prevents anterior tibial translation. The hamstring's not strong enough, could shear too much and just tear that ACL, right? There's also some cool research about timing of muscular contraction. So if you land and the quad fires before the hamstring, thought is you're getting that shear in the absence of any sort of restriction from the hamstring. So interesting stuff. I mean, this study did suggest that's a problem, right? The other thing they found, which is also interesting, is greater knee extension muscle strength correlated with more injuries, which kind of makes sense too. If that quad is overpowering the hamstring, getting more anterior shear forces, forcing more strain on that ACL, causing more injury. And the last one is longer soccer experience. So if you played for more years, then that also correlated with injury too. So any thoughts on this one, Kevin? Kind of interesting.
Yeah, it is. I think we hyper focus on the quads in rehab post-op, and for good reason, I think. But I think this is important if we're looking at potential predisposing factors for who's tearing their ACL, to look at hamstring as well and make sure that we're getting like good co-contractions and we're hammering both sides of the lower extremity, the quad and the hamstring. So that is interesting, and it makes intuitive sense. I think it'd be good to see with higher powered studies if that continues to play out. But I think definitely just for performance too, that's something we're looking at, is the hamstring to quad ratio. And like you said, I think over that 60% is probably a good minimum to shoot for. And I usually say about 2/3 or something like that. Like you said, it would be very strange if it was a 1-to-1 ratio. Something's wrong with the quad. But yeah, you don't want like under 50%. That'd be bad too.
Yeah, makes all sense. Very interesting. It seems like it is still a relevant thing. So,
Yeah.
all right. So now we're looking at predisposing extrinsic risk factors. So previously we're looking at intrinsic risk factors, things like strength, things like the size of the ACL. These are extrinsic risk factors, things like weather, right? Things like shoe wear. So a different type of risk factor. This was also a recent study in 2024 entitled Extrinsic Risk Factors for Primary Non-Contact ACL Injury in Adolescents, aged between 14 and 18. So take in mind, this is 14 to 18-year-olds, different than college or professional, right? And they're examining prior risk factors linked to primary ACL injury. Similar to the last study we talked about for intrinsic risk factors, they were kind of doing the same thing, but with these extrinsic risk factors, with hopefully a higher powered study, right? Because more and more studies are released over the course of time. They're trying to see if these former extrinsic risk factors that were related to injury are still going to be relevant when there's a higher powered study available. So they used 16 total studies. So the extrinsic factors they were looking at was the specific sport. So let's say soccer versus football versus basketball. This was in 8 studies. They're looking at sport exposure amount. So maybe like the total hours of participation in 5 studies. looking at the sport level. So think about middle school, high school, and then collegiate and professional. That was in 3 studies. Looking at sport season in 1 study, looking at in the environment in 2 studies, and looking at equipment in 1 study, things like shoes. Basically, there is contrasting evidence about associations between sport exposure and biomechanical/neuromuscular risk factors. There is weak evidence of differences in biomechanical risk factors. So essentially what they're saying in this study is that some of the prior research that was looking at, let's say, dynamic valgus when people are jumping and landing, let's say the firing of the quad versus the hamstring, some studies were in favor of this being a risk factor and some was not, right? So kind of interesting that there's been so much research over the course of time that it gets even more confusing. And one thing they did show is higher sport level may be associated with increased injury risk. And this is pretty consistent with a lot of the other studies that I saw. But I just thought that was pretty interesting that in this study, they didn't find many, if any, extrinsic risk factors were actually relevant to injury. Similar to the prior study on intrinsic risk factors, basically when they have a bigger study with more sports involved, it didn't make a lot of sense to me because essentially, like, it seems pretty clear that you would have more injuries in soccer compared to something like powerlifting. You know what I mean? I don't think they include any powerlifting studies, but it would make sense that there'd be a difference. I wanted to include this because this was a little bit different than a lot of the other studies that I saw, and it was more up to date. But again, it was just confusing to me. It's like, okay, this doesn't even make sense, right? Any thoughts before we move on?
Yeah, I think, like you said, it is a little bit confusing, have to dive into it, but you do hear oftentimes people say like I think I tore it because I was playing on turf instead of grass, or I was wearing my turf shoes instead of my cleats, or something like that. And or it was crappy weather, stuff like that. So I think we'll need more information on this. But I could think, like you said, at least this study wasn't finding anything too definitive in terms of those types of things. But I totally agree with you. Like there has to be, I wonder what those 8 studies that included different types of sports. Was it like lacrosse versus soccer versus, very similar sports? It's not going to show a difference because obviously we know that certain sports, your risk is just going to be lower. Like, I'd say a soccer goalie or a hockey goalie would have to have a lower risk than a soccer forward or like a lacrosse, attack player or something like that. So I think we could use our common sense with that kind of thing. But, interesting study though, and nice that it's new.
I know. I think one of the takeaways is maybe that these things aren't that important in the grand scheme of things, right?
Hmm.
You certainly, I mean, there's research that shows like the amount of rain you get over the course of season correlates with the risk of injury. And when it's drier, the idea is that when you plant, your foot doesn't spin as well as if it
Hmm.
rains a certain amount over the course of the month. Where when your foot spins, the cleat will spin in the ground because the ground is softer, right? So yeah, you will find that research as well, but maybe it's not as important as we thought in the past. Maybe that was kind of my takeaway.
Hmm.
So, all right. So let's look at some other risk factors that popped up a lot, and these were individual studies. So you take this with a grain of salt because the prior studies didn't really show the same results, but a lot of this makes a lot of sense to me intuitively. And I looked at a few different studies here. But essentially, does the sport that you play, your sex, and your level of competition influence your rates of injury, right? And essentially, being a college athlete, you have a higher injury risk over high school athletes. And this was consistent with those other systematic reviews. And then females were greater than 2 times as likely to be injured as males, which we know that. Okay, so that's consistent with some of those other reviews. This study was showing only 2 times as likely, although we said up to 8 times, depending on the study. Also, your relevant risk is greater in basketball and soccer than other sports. For female, soccer is the number 1 rate of injury, and then followed by basketball and followed by lacrosse. For males, it's a little bit different. Number 1 is football, followed by lacrosse, then followed by soccer. And the other stat that I thought was interesting is that you were 6 to 8 times more likely to be injured during a match or a game situation compared to practice. Any thoughts on that? These studies were a little easier to wrap my brain around and a little bit more in terms of my expectations.
Yeah, I think a little more consistent, right? I agree with you there. And then in terms of, more likely to tear during a match, I think that kind of correlates with that finding that we see that higher level athletes are more likely to tear than lower level athletes. And it's, it's probably effort related. So if you're, comes down to forces. If you're running really hard in a match, your effort level's higher, you're probably producing more force with running and cutting. And we see the injury maybe occur in that setting a little bit more. So I think that definitely makes sense.
All right. So now you know what you need to know about ACL injuries. Oftentimes, ACL injuries come with meniscus injuries. Well, I have a video for you, and it lives right over, right over Kevin's head over here, where we go over everything you need to know about meniscus injuries. Go ahead and click on that link, and I'll see you in there. We go over this common injury often associated with ACL tears. See you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.